Welcome everyone. Let me introduce my PhD thesis topic, which is the importance of pancreatic exocrine insufficiency in pancreatic diseases. My name is Orsolya, Eperjesi, and my vision is an early diagnosed and appropriately managed pancreatic exocrine insufficiency across pancreatic diseases. And to achieve this, my mission is the optimization of pancreatic enzyme replacement therapy in acute pancreatitis patients. For these goals, I have 3 ongoing projects. My first project aims to investigate the risk factors of pancreatic exocrine insufficiency and the effects of pancreatic enzyme replacement therapy in patients with acute pancreatitis. As the survival rate after acute pancreatitis has improved dramatically over the decades, it is important to see how AP survivors live and how an episode of AP changed their day-to-day activities. A previous meta-analysis by Huang et al. Demonstrated that there is a high prevalence of PEI in patients with acute pancreatitis, both during their initial hospitalization and in the long-term follow-up. And untreated pancreatic exocrine insufficiency can cause several intestinal symptoms, such as abdominal pain, bloating, cramping, increased flatulence, stultorrhea, and diarrhea, and all these pathological changes seriously affect the patient's quality of life with pancreatic exocrine insufficiency. Despite it, there are still many uncertain aspects regarding the treatment of patients with post-AP PEI, and less is known about which patients need to be screened for PEI after an episode of AP. Therefore, our aim is to identify the risk factors of PEI and investigate the effects of PERT in acute pancreatitis. We asked the question, what are the rates and the predictive factors of PEI in acute pancreatitis? We used the COCOCOP and the PFO framework, and we hypothesized that the rate of PEI symptoms is increased among patients with acute pancreatitis, and there are risk factors that can predict PEI in acute pancreatitis. We conducted a systematic search within 3 databases, and after the whole selection process, including the citation chasing, 54 articles were eligible for systematic review and meta-analysis. The statistical analysis has been finished, so let me show you some of my results. On the first plot, you can see the proportion of PEI at discharge. The overall measurement of the proportion is 0.64, meaning that 64% of AP patients have PEI at the time of hospital discharge. We also examined the PEI rate during the AP follow-up. On this plot, you can see results for the first year follow-up. And however, we can recognize some recovery in the pancreatic function. In 20% of AP patients, PEI still persists. This is important because, as I mentioned, untreated PEI can decrease the patient's quality of life and leads to malabsorption and malnutrition. We also wanted to see which factors can affect the PEI development after acute pancreatitis. Therefore, our next outcome is the odds of PEI development. And here we are comparing patients with alcohol-induced AP to patients with biliary AP. And based on our results, having alcohol-induced AP is associated with a higher risk of PEI development, although this result is still not statistically significant. On this plot, you can see results for the same outcome, the odds of PEI development. However, here we are comparing patients with severe acute pancreatitis to patients with mild acute pancreatitis. And based on our results, the odds of PEI development is 2 times higher among patients with severe acute pancreatitis. Furthermore, we compare patients with infected necrosis to patients with sterile necrosis, and the odds of PEI development were almost 2 times higher among the patients with infected necrosis, although it doesn't reach the statistical significant level yet. On the other hand, we compare patients who underwent a necrosectomy to patients without necrosectomy, and based on our results, the odds of PEI development is 3 times higher in the necrosectomy group. The strengths of our study included that we have robust scientific methodology and clinically relevant subgroup analysis. However, the meta-analysis was limited by the fact that the outcomes definitions were varied among the studies, and they have checked the outcomes at the different time points. In conclusion, our results shows that more than half of the EP patients have a PEI at the time of hospital discharge, and quarter of them during the EP follow-up. Moreover, severe acute pancreatitis and necrosectomy is associated with an increased risk for PEI development, and there is a clear tendency for increased risk for PEI in infected necrosis. Based on our results, we can recommend screening EP patients for PEI after acute pancreatitis, and early PERT administration should be considered in case of severe acute pancreatitis. As regards the implication for research, further studies are needed to investigate the role of infection in PEI development and the effects of PERT in acute pancreatitis. I have written the manuscript, and we plan to send it to internal review in this week. And let me introduce my second and the third project, which aims to investigate the risk factors and management differences of patients with calcifying chronic pancreatitis with two different methodologies. Due to the limited time, I will introduce them together. Why this topic is important? Because pancreatic calcification is the most frequent structural change observed in chronic pancreatitis, regardless the etiology, and those patients who has calcification in the pancreas more likely to have severe abdominal pain, malabsorption, more often need hospital admission or even surgical treatment. Less is known about factors associated with calcification in patients with chronic pancreatitis. Therefore, our aim is to investigate the risk factors of calcification in patients with chronic pancreatitis. Our question is, what are the factors and management differences among patients with calcifying chronic pancreatitis? During the second project, which will be a systematic review and meta-analysis, we will use the PFO framework and focus on the risk factors. And the third project will be a registry analysis of the patients with acute and chronic pancreatitis, and we will investigate both risk factors and management differences. And our hypothesis is that there are specific risk factors that can predict calcification in chronic pancreatitis, and by identifying the modifiable risk factors, we can help prevent or at least slow the progression to calcification. As an overview, I have 3 ongoing projects. My first project aims to investigate the predictive risk factors of pancreatic exocrine insufficiency and the effects of pancreatic enzyme replacement therapy after acute pancreatitis, and we plan to submit it at the beginning of September. And the second and third project aims to investigate the risk factors and management differences of calcification in patients with chronic pancreatitis with 2 different methodologies. And I would like to close my presentation with the words of Rosalind Franklin: "Science and everyday life cannot and should not be separated." Thank you for your kind attention.
Congrats on your presentation. I have a question regarding your first project, the diagnosis of pancreas exocrine insufficiency. How was it diagnosed in your included articles in the meta?
It was one of the limitations of the study that different diagnostic methods were used among the articles. But in the latest PEI guidelines also highlighted that we should not only focus for the functional test, because the PEI definition also changed. We should consider PEI as a malabsorption syndrome. So the diagnosis is very challenging. It means that we should evaluate the nutritional status, the patient symptoms, and the functional test together. So we can't accept only the functional test.
I see. Thank you.
And do you have information about the severity of PEI, and was it influenced by the different etiology of or different severity of acute pancreatitis?
We didn't examine it separately, so we haven't make a separate analysis based on the severity of the PI. We just examined the severity of AP.
Is there any data in the future about the severity? Yeah, because
yes.
all the test is valid to judge the severity of PI, but there is some data.
Yes, there were articles where they mentioned that the severity of AP affect the severity of PEI as well, but we didn't examine it.
Based on the studies you analyzed, I wonder how big proportion of the patients received enzyme replacements during the acute pancreatitis.
We also have a forest plot for that, but due to the limited time, I couldn't present it. During the follow-up, about 20% of AP patients received enzyme replacement.
Congratulations. You mentioned that right after the acute pancreatitis, there is a 46% enzyme deficiency, and after 1 year, there is 20%.
Yes.
So it is a kind of improvement. So what can be behind that? How do you explain that?
I think it mainly the resolution of the inflammation, because the infection can decrease the sensitivity of the acinar cells. After the resolution of the inflammation, it can improve.
Thank you.